Hi YouTube family, welcome to Concept in Medicine. In today's tutorial, we are going to be looking at upper motor neuron lesions and lower motor neuron lesions. Excited, right? Kindly subscribe to my channel so that I will keep bringing you beautiful concepts in medicine. Let's proceed. So when we talk about upper and lower motor neuron lesions, first of all, we want to know what an upper motor neuron is, what a lower motor neuron is. And again, we want to know where the upper motor neuron emanates from and where it ends, and where the lower motor neuron starts and ends. So in that regard, we'll be looking at the structure of the central nervous system and portion of the peripheral. That is the brain and the spinal cord, in addition to the peripheral nerve. So if you look at this diagram carefully, we have the cerebrum, which is made up of what? Two cerebral hemispheres. So we have the right cerebral hemisphere and the left cerebral hemispheres. And here, this region of the cerebrum, we call it the cerebral cortex. And you should know that the inner aspect of the cerebral cortex is lined with myelinated axons. Because of that, it gives it a color white, thereby the name white matter. But if you go to the outer aspect, it has a lot of cell bodies which are not myelinated, therefore we call it the gray matter. Again, if you take the cerebral hemispheres, for majority of individuals, for almost everyone, you have the left cerebral hemisphere being dominant. I hope you get that. And it tells you that a lot of people on this earth are right-handed, few are left-handed. So that makes it more of what? A dominant left cerebral hemisphere. If you come down a bit, you have what we call the internal capsule. The internal capsule is that location in the cerebral cortex that contains the highest amount, or that has the highest amount of myelinated axons. Then, if you look up again, we have an area here. We call it the primary motor area, or what you call the primary motor cortex. When we talk about the primary motor cortex, that is where every motor impulse would emanate from. Every motor impulse will emanate from the primary motor cortex. Then we should be asking ourselves, how can we locate the primary motor cortex? The primary motor cortex is located in the precentral gyrus at the dorsal aspect of the frontal lobe. And if you are using the Brodmann classification of the areas in the brain, then it will be located at Brodmann area 4. Brodmann area 4. It coincides with the primary motor cortex. Since we've spoken about the primary motor cortex, let's zoom in on what we call the primary somatosensory cortex. The primary somatosensory cortex has nothing to do with what? The motor impulses. But because we mentioned the primary motor cortex, that is why it will be advisable to just talk about it. So the primary somatosensory cortex is located at the postcentral gyrus at the anterior aspect of the parietal lobe. And you should know that if we are using the Brodmann area classification, then the primary somatosensory cortex will be located at Brodmann area 1, 2, 3A and 3B. So those are the locations using the Brodmann area classification for the primary somatosensory cortex. Interesting, right? Let's move on. Now, you move on again, just below the cerebrum, we have what we call the brainstem. And the brainstem has three divisions, three portions. That is the midbrain here, the pons here, and the medulla here. So together you call it what? The brainstem. In the olden nomenclature, the brainstem, looking at it, it has that appearance like a bulb. Because of that, in the olden nomenclature, and there's an adjective that is used to describe the brainstem. We call it bulbar. So if you have a motor tract beginning from the cerebral cortex and ending in the brainstem, then we'll call it what? The cortico-bulbar tract. That makes sense to you, right? Yes. Let's move on. In the brainstem, when we take the midbrain, you will have what we call the red nucleus. And the red nucleus, you should know that the red nucleus functionally allows for the disinhibition of flexor response. So if you look at that very carefully, it means the red nucleus, if functional, promotes flexion. And we can do an application with regards to the Glasgow Coma scale. If you are looking at a Glasgow Coma scale, at the best motor response, you will give a score of 3 if there is an abnormal flexion, which will give rise to what we call the decorticate posture. Why does it have to happen? It tells you that for that score of 3, for the best motor response being an abnormal flexion response, it means that the lesion which give rise to the injury, the brain injury, is located above the red nucleus, allowing the red nucleus to function effectively, thus promoting flexion response. So the patient will always be in a flexion position like this. That's what we call the decorticate posture. And that attracts a score of 3 when you are looking at the best motor response component of the Glasgow Coma scale. I hope that sounds interesting to you. Yes, let's move on. Now, if you move again, we have what they call the crus cerebri. It's more like a pedicle of the cerebral aspect. Then we move to the pons, then medulla. If you look at the medulla, it has a structure we call the pyramids. The pyramids, they look like a triangle, pyramid, meaning that any motor neuron or any motor tract that goes through the pyramid will be considered as a pyramidal tract. And any motor tract that goes outside, that moves external to the pyramid, will be considered as what? An extrapyramidal tract. Now, look at this. You should also know that majority of the motor tracts, they go through the lateral corticospinal tract, as I've demonstrated there. This is the lateral corticospinal tract. And the lateral corticospinal tract, as we are saying, majority of the motor tract goes there, meaning that 90 to 95% of motor neurons will go through the lateral corticospinal tract, allowing only 5 to 10% to go through the anterior corticospinal tract. Another interesting thing that you should realize here is that all the motor neurons or tracts going through the pyramid, they decussate, meaning that if they are moving on the left, they would branch to the right. That's what we call decussation. At the level of the pyramid, the moment they exit the pyramid, they decussate to the contralateral side. So you can see that the primary motor cortex is located in the left cerebral hemisphere, but as the tract move together with the motor neuron, the moment they go through the pyramid in the medulla, what happens here? You will see the decussation from left to right, meaning that any motor neuron or tract that is going through the pyramids of the medulla will decussate at the level of the medulla. That will be from left to right and vice versa. Now, if you take a motor neuron or a tract moving external to the pyramid, then they do not decussate at the level of the medulla. Where do they decussate? They will be decussating at the level of the spinal cord, meaning that those motor neurons or tracts will go through the anterior corticospinal tract, unlike those that are using the pyramidal pathway. For the pyramidal ones, they will go through the lateral corticospinal tract. Introspection, we can say that majority of the motor neurons would go through the lateral corticospinal tract, meaning they will go through the pyramid in the medulla. That sounds interesting, right? Definitely. That is why we are using the concept to understand upper and lower motor neuron lesions. Let's move on. When you come to the spinal cord, as you can see, the spinal cord has a canal at the center. We call it a central canal. Then again, we have the dorsal root, which is where the sensory neurons will go through. Then we have the anterior root, or what we call the ventral root. That is where the motor neurons will go through, as you can see. Then we have what we call the posterior horn cell. Then we have what we call the anterior horn cell. And for this topic, that's the upper and lower motor neuron lesions, our reference point is going to be the anterior horn cell. This, we are going to be making a lot of referencing to that. So take note of that. Then again, if you look at the spinal cord, the internal layer is the composite of the brain, meaning that the internal layer will be described as what? Gray matter, and the external or outer layer will be known as what? The white matter. Why? Because wherever myelinated axons are concentrated, we will have the white matter. But wherever cell bodies are concentrated, we will have what? The gray matter. So if you look at this very carefully, going through this path, we have the myelinated axons. That would make it what? White. But if you come here, you're going to have the cell bodies. That will give it a gray appearance. Thereby, we call it what? The gray matter. Now, from there, if you have a motor neuron beginning or arising from the primary motor cortex, going down through the internal capsule, which is a motor structure, then going through the red nucleus, another motor structure, then going through the through cerebri, then through the pyramid, then it will bifurcate and come to the spinal cord and come and synapse at the anterior horn cell with the lower motor neuron. So all the way from the primary motor cortex and ending at the anterior horn cell, this becomes the upper motor neuron. As you can see, the upper motor neuron moves all the way from the primary motor cortex, going through all those motor structures and ending at the level of the anterior horn cell. We call that the upper motor neuron. Then at the anterior horn cell, the upper motor neuron synapses with the lower motor neuron. So you see, the lower motor neuron begins from the anterior horn cell and go all the way to the skeletal muscle, which is the effector, and gives it innervation to contract. So if you put your hand on a hot plate, what will happen? You have sensation. The primary somatosensory cortex will become activated, and signals will be sent to the primary motor cortex, and the primary motor cortex will relay these signals to the upper motor neuron. Then the upper motor neuron will take the signal, move through all those motor structures along the tract, the motor tract, and come all the way to the anterior horn cell, synapsing with the lower motor neuron for the lower motor neuron to transmit that motor impulse to the effector, which is the skeletal muscle, for it to contract. And that would mean that you are withdrawing your hand from the temperature stimulus. I hope that makes sense to you, and you have been experiencing that almost every time at homes when you are cooking. Okay, let's proceed. Now the next thing we want to talk about is the upper motor neuron and the lower motor neuron. I've already given you where the upper motor neuron begins from and ends. I told you it begins from the primary motor cortex, that is in the frontal lobe, where in the precentral gyrus, where at Brodmann area 4, at the dorsal aspect of the frontal lobe. We made mention of that before. Now it begins from there and goes all the way through the cerebral cortex, going through the brainstem, and finally ending at the anterior horn cell of the spinal cord, where it synapses with the lower motor neuron. Now, you should know that the upper motor neuron belongs to the central nervous system. And what does the central nervous system consist of? It consists of the brain and the spinal cord. And you should know that the upper motor neuron controls, look, the upper motor neuron, as you can see here, it controls the brainstem, the spinal cord, it controls the brainstem, the spinal cord, and the effector. That is the skeletal muscle. And if I'm saying the effector in another way, I mean that the upper motor neuron controls what? The lower motor neuron. So in short, the upper motor neuron controls the brainstem, the spinal cord, and the lower motor neuron. Interesting, right? Okay, let's move on. What of the lower motor neuron? The lower motor neuron belongs to the peripheral nervous system, meaning it's comprising of, we are looking at the nerve roots, these nerve roots that we've described here. We are talking about the ganglion, the peripheral nerves, the neuromuscular junction, and the effector, that's the skeletal muscle. I hope it's getting interesting as we are proceeding. The next thing we are going to be talking about is how to distinguish between upper motor neuron lesions and lower motor neuron lesions. And we are going to do that in a tabular format. So the first parameter is the etiology. The upper motor neuron lesion, where is the lesion? The lesion occurs above. It's going to be above the anterior horn cell, meaning that that will be the demarcation of the end point of the upper motor neuron lesion. So for upper motor neuron lesions, the lesion occurs above the anterior horn cell. What of the lower motor neuron lesion? The lesion occurs at the level of the anterior horn cell or below it. So it's either here at the level of the anterior horn cell or below it, and that would constitute the lower motor neuron. I hope that is clear. Now, the next parameter is we want to look at the conditions. Which conditions can be considered as an upper motor neuron lesion and which can be considered as a lower motor neuron lesion? So the first one you should think of is what? Stroke. That's cerebrovascular accident. We can also think of infections such as CNS toxoplasmosis, encephalitis, cerebral abscess. Then the next one is the tumors. Which tumors are we looking at? The brain tumor, the spinal cord tumor. Then the next one that we can also think of is what? A primary lateral sclerosis. It's also an upper motor neuron lesion. We can also think of injuries to the spinal cord. Which injuries are you looking at? We are thinking of what? Tethered cord and what? Cord session. Then again, another one we can think of is what? Multiple sclerosis. And finally, we can also talk about cerebral palsy. So cerebral palsy is also an upper motor neuron lesions. What of the lower motor neuron lesions? For the lower motor neuron lesions, we can think of neuromuscular junction disorders. What are we looking at? Under that, we can think of botulism. And for botulism, you should know that it's a presynaptic disorder. The disorder is in the presynaptic zone. Then we can also think of myasthenia gravis. For that one, it is a postsynaptic disorder. Then we can also think of Lambert-Eaton syndrome. For that one, it's what? Presynaptic. Another thing we can think of under the neuromuscular junction disorders or disease is aminoglycoside toxicity. Yes, those are the neuromuscular junction disorders. Other lower motor neuron lesions, we can think of poliomyelitis. We can think of amyotrophic lateral sclerosis, ALS. I believe you remember ALS, the ice bucket challenge. Do you remember? Yes. The next one we can think of is poliomyelitis. We can also think of what? Leprosy. We can also think of transverse myelitis. We can also think of Bell's palsy. Then we can also talk of what? Duchenne muscular dystrophy. Duchenne muscular dystrophy. And then finally, Guillain-Barré syndrome. Guillain-Barré syndrome. I hope we are enjoying the lesson. Let's move on to the next category. And the next parameter is going to be the clinical presentation. So for this, there's a trick. Let me show you the trick. When we say upper, it means it is higher. When we say lower, it means that it's lower. So for upper motor neuron lesions, everything is going to be high, except 1 or 2. Or another way we can put it is, you can take the upper to be the father and the lower to be the son. And you know, if the father is not at home, the son becomes chaotic. If the father is not at home, that is upper motor neuron lesion, the son becomes chaotic, and that everything will be high. So for the upper motor neuron lesion, everything is going to be high. Then for the lower motor neuron lesion, if the child is sick, the child becomes very dull, low in activity. That gives you everything low. So with that, the first clinical presentation distinction that we want to talk about is the tone. For the tone, as we said, if it's upper motor neuron lesion, it will be high, so hypertonia. Lower motor neuron lesion is going to be low, so hypotonia. The next one is the paralysis. If we take the upper motor neuron lesions, there's going to be spastic paralysis in a clasp knife-like function. I believe that you know the clasp knife. Okay, it's also known as the Swiss knife. For the Swiss knife, if you want to open it up, you meet a level of resistance, and if you are able to overcome that resistance, then it's open. That is how the patient's arm is going to look like. For example, if you take a stroke patient or cerebral palsy patient, there's this kind of stiffness that you cannot overcome. That becomes what? The spastic paralysis. Okay, for the lower motor neuron lesion, it is going to be a flaccid paralysis. Flaccid. If you take the arm, it will just fall. You take the arm, it will just fall. There's no spasticity there. It's flaccid. The next parameter is we want to talk about the reflexes. Again, upper motor neuron, there's going to be hyperreflexia. Lower motor neuron, hyporeflexia. Still under the reflexes, we can think of the deep tendon reflexes. For upper motor neuron, it is going to be elevated or increased. For lower motor neuron, it's going to be decreased or absent. Okay. The next we want to talk about is the abdominal reflexes. For this one, it is an exception. For the upper motor neuron, the abdominal reflexes are going to be absent, but for the lower motor neuron, it is going to be what? Present. The next one, Babinski reflex. The Babinski reflex is also known as the extensor plantar response. What does that mean? It means that we are going to go along the lateral plantar aspect. Okay, the lateral plantar aspect of the foot. That's of the sole. Now the lateral plantar. This is if you take the hand, let's take the hand as a foot. Below it is what we call the sole or the plantar surface. So you go at the lateral plantar aspect. If this is your big toe is what? Medial. Small toe is what? Lateral. So you are going to go laterally. So you are moving towards the lateral aspect. So the lateral plantar aspect is what? Stimulated, okay, or striked firmly with a neurotip. And what will be the response? You will witness a dorsiflexion, or what we call extension of the big toe with fanning of the remaining toes. With fanning of the remaining toes. So there's extension or dorsiflexion of the big toe with fanning of the remaining toes. Babinski reflex is positive when you elicit what I just described. And you should know that in children below the ages of 2 years, it is physiological. If it's positive in children below the age of 2 years, it's physiological. But above the age of 2 years, then it becomes what? Pathological. And this is positive in upper motor neuron lesions. But for the lower motor neuron lesions, the Babinski reflex is going to be absent. The next parameter we want to talk about is Clonus. Clonus is present in upper motor neuron lesion and is absent in lower motor neuron lesion. Then somebody will ask, what is Clonus? For Clonus, we will say that Clonus can be elicited by a rapid dorsiflexion of the foot, producing more than 3 uncontrolled or involuntary rhythmic motions of the foot. So in that case, what are we talking about? let's take this as the foot. Your hand goes below it and what? You rapidly dorsiflex it. If you rapidly dorsiflex the foot, what will happen is that you will see the foot moving more than what? 3 times, and it's not controlled by the patient. You see it moving more than what? 3 times. It's going to follow a particular rhythm, but just that it is uncontrolled or is involuntary. If it is such, then we'll say that is Clonus. And you should know that mostly for Clonus, it means that when you rapidly dorsiflex the foot, what is going to happen? There is going to be stretching of the fascia of the gastrocnemius muscle, and that is what is going to produce the movement. So if that control over the muscle is interrupted as a result of what? An upper motor neuron lesion, then the movement becomes what? Uncontrolled. I hope that clears your doubt. For the lower motor neuron lesions, Clonus is absent. Now, the next thing we will talk about under the reflexes is fibrillations and or what? Fasciculations. Fibrillations and fasciculations, they are absent in upper motor neuron lesions, but they are present in lower motor neuron lesions. Then the question is, what is fibrillation? What is what? Fasciculation. For fibrillation, it's contraction of a single muscle fiber, but for fasciculation, it's contraction of what? A group of muscle fibers. Now, the next category is what? Muscle atrophy. For the upper motor neuron lesion, there is going to be disuse atrophy. Why am I saying disuse? Because there's spastic paralysis. If your hand is shaking, definitely you cannot hold the cup. If you hold the cup, it will fall. And you should know that anytime the muscles are not in use, they undergo atrophy. So for upper motor neuron lesion, it's not that there is no nervous supply. There is a nerve supply, just that because of the spasticness of the muscles, the muscles are not used for anything. So that will give rise to the disuse atrophy. Lower motor neuron lesion, in that case, the nervous supply or the nerve supply to the muscle is cut off. And in that case, we are going to have denervation atrophy. The next category is power. For the upper motor neuron lesion, there is going to be partial loss of power because, controlled conduction is no longer there. But for the lower motor neuron lesion, since the nerve supply is cut off, there is complete loss of power. Then finally, distribution of muscle weakness. For the upper motor neuron lesions, the distribution will follow a pyramidal pattern. There's going to be a pyramidal pattern of what? Distribution. And what does that mean? If we take the upper extremities, the extensors are going to be involved, leaving out the flexors. So for the upper extremities, the extensors are affected, the flexors are intact. But if you go to the lower extremities, vice versa, meaning the flexors will be affected in the lower extremities and the extensors are going to be intact. And if you take the lower motor neuron lesions, all muscle groups are involved. All muscle groups are involved. I hope we've made a lot of sense out of this. Thank you very much for staying through the lesson. Kindly make sure to subscribe to Concept in Medicine, like, share, and also don't forget to comment which concept you would like to see in my next video. My name is Dr. Del, and this is Concept in Medicine. See you next time. Bye-bye.